Okay, welcome everyone. I am Maxine. I also have two of my very good friends and colleagues here from South Africa. So I'm really happy to welcome you guys. We're going to be talking about material science today of injectable composites that we use for our anterior aesthetic cases. Um, so this is the town I come from, and I've been practicing for the last 10 years. And the thing that I have noticed with failed restorations is they always tell us a story. They tell us a story of the clinical skill of the dentist, or mostly what we see is they tell us the story of the material not being understood. And in order for us to have success with flowable composites, injectable composites, we need to understand how the material works with light, under stress, how it flows, and how it performs over time. And the only way we can know that is by looking at the material science of the composites that we're using. So as dentists, we often look at aesthetics, longevity, the biology, we look at emergence profiles, symmetry, proportions. But what happens, for example, if we have a discrepancy in size? Do we sacrifice tooth structure? Do we settle for a compromised outcome? Or do we start thinking out of the box? And I generally like to take the box and throw it out of my practice. So if we understand our material, we can actually manipulate how light reflects off the veneer surface in order to give us the appearance of the anatomical size that we want or shape that we're looking for. So in order to do that, I'm going to simply explain what we should be looking at when we are making a selection in terms of our injectable composites. So composite comprises of three main components: an organic matrix. So this is what we call our difunctional monomers or methacrylate monomers. And that's basically your TEC GMA, your UDMAs, your BIS GMA. It also has your stabilizers as well as your pigments. Too much of this and we increase, so in your composite, if you have too much of this component, you're increasing the polymerization shrinkage of the material. You are also decreasing the wear resistance and the stability of the material over time. Too little of this component means you have a very brittle material. I'm sure we've all used a composite that sticks to all your instruments. It's because it has too little of this component. So the next thing we'll talk about is inorganic fillers. So we all know fillers and how important fillers are, like your glass silica and all of these ceramic type fillers that we now have in advanced composites. What we need to think about is the size, the distribution of it, and the loading or the weight filler content of a material. When you have too little of this, you increase the flowability of the material, but at the cost of the mechanical properties. But when you have more of it, so a higher filler content, then you're increasing the mechanical properties, the flexural strength, the wear resistance, as well as the optical properties of the material. So, I want to move. The next important thing is a silane. And basically what a silane does is, for example, can you come here? So organic matrix, inorganic filler, silane does this. So if we have a Velcro here and a Velcro here, it bonds, it's the molecular bond and bridge between the two things, giving us that stability long term. So when we have effective silanization, basically what's happening is we have increased flexural strength, better wear resistance, brilliant optical properties, and a very big important thing is a decrease in water sorption. So that means that it goes in and it binds to the resin matrix, giving us stability in material over time. Please, if you have a question, just stop me as I'm going. So if we look at this case, immediately we know this is failed dentistry or the outcome is not what we would like. This was done for this patient about a year before I saw her at another dentist. And when we look at this, we say, oh, it's terrible, but we need to think about what happened. Why did this happen to the patient, or was the outcome, so that we don't repeat that in our retreatment. So if we look at the brown staining and the chipping, it tells us two things. There was a higher organic content in this composite that was chosen, as well as very large filler particles that were chosen, or in the composite itself. So what happens when your filler particles are too, or in your resin matrix is too big, over time the wear starts to chip the matrix. And so you will get pitting in your material, bacterial adhesion, and staining. So the browning is also from water sorption and the material not being stable over time. So this is where our star of the show comes in, S-Flow plus Injectable composite. They have developed a beautiful silane technology that coats our filler particles so that we get a dense, evenly dispersed distribution. And the filler particle size is 180 micron, which is very tiny. And by giving us this densely packed, even distribution of filler particle, we are able to have increased mechanical properties without compromising the optical properties, your polishability and end result. So we get a good long-term surface finish on your veneer. There are two numbers in dentistry that are very important when we're talking about this type of material. It's your flexural strength, and we want to have materials that behave very closely to your natural teeth. Enamel, the flexural strength is about 179 megapascal, and this flowable is 137 megapascal. So if you're sitting too far away, the physical forces that are applied between those material and the bond becomes a problem. So it's good that we have something that's pretty close to our enamel so that it can behave like the tooth when stresses are being applied, especially in the anterior area. The next thing is this filler weight. And it's 68% full, which means it's a highly filled nanohybrid material, which is what we want. This is what we're looking for in a flowable. So we have a high filler content, again, so we're getting the good optical properties as well as the mechanical properties. So I'm just going to take you through a clinical case. This was an 18-year-old gentleman who presented and he needed a root canal, so we completed the root canal for him, and then we decided, okay, he didn't want to do a crown at the time, so we decided, okay, well, we'll restore it with composite. So we etch bond, of course, and then we build the palatal shell. We built the interproximal, and then we did mamelons. So what we did is I used the clear shade on the palatal, we build up the side, and we use a little bit of a darker shade to create the mamelons, and we go over with a final shade. We do our anatomy. So if you do this kind of anatomy on your anterior teeth, almost always the light will bounce off your material once you finish polishing beautifully and you get a good aesthetic result. The other thing is just a little tip as well. If you're using an electric motor, you turn the water off and you use it on a low speed and you get this fine powder that happens, and that also shows you your anatomy and you can see quite clearly what you've created. And that's our end result. So this is a skeletal class 3. It's under a lot of force and pressure, stress, and this was about 6 months ago. I saw him in Jan from when we did it, and there's no chipping, there's no staining, so we got a really good result. So something to mention, there it is. You can see this little line here. Okay, so that happens when we don't do an infinity bevel. What that means is we create no undercut for the material to sit through and shine and create this effect. But in a scenario where I have minimal tooth structure, that's a small sacrifice that I'm willing to take to conserve as much tooth structure as we can. Okay, so the next thing I want to talk about is fluorescence. Not many people speak about this. What's really important is that, again, we want to emulate what the tooth is doing. Natural teeth have fluorescence. So your dentine has something called fluorophones. And when you have a UV light that's exposed to the tooth, the tooth will emit a whitish bluish hue. And when you're in the club and your friend has composite veneers, or the bar, and your friend has composite veneers and she smiles, that's really not a... Now everybody knows she has composite veneers. So we need to have a composite that will have also fluorescence added to it so that it can be as close as it would be to the tooth. So I tried to show you guys here, but it doesn't look as bad, it doesn't glow as much as that. So this is already a much closer to the tooth in terms of fluorescence. Okay, so injectable is very much a big word at the moment, and when we're looking at why we will call something an injectable is we want to look at as I said, a highly fold nanohybrid material. It's versatile. It has great mechanical properties, good flexural strength, increased wear resistance, as well as polishability, because of the filler technology as well as the silanization that goes on. So this is the only material I've used that is able to stack the way it does without collapsing, meaning it gives us, the clinician, time to place the composite and move it to where we want it to, or place it and it doesn't move, which is really important because it gives you time to do what you need to do, meaning less stress. I'm going to talk about technique briefly. So injection molding is widely used at the moment. It's all over social media, but this technique was actually developed in 1872. And Terry Douglas first started publishing a whole lot of articles, and then he subsequently published a book in 2014. And then Christian Coachman came through and he introduced the DSD protocol in 2020. But this technique gives us predictability. What we see is generally what we can give to the patient at the end result. So we have an initial 12 o'clock picture as well as the mock-up digitally. We can now start to work on tooth proportions and everything that we want, buccal corridors. We are able to design all of that and redesign it until we are happy with the end result. So this is the initial. You can see that the 11, the 21, and the 22 are all 3 different sizes. And this is our digital model. We then made a mock-up because this patient was super nervous, and we transferred it into her mouth. And this was the end result. What's important about injection molding is that your composite is not exposed to oxygen, meaning it's fully cured. So you don't have to use, if you are happy with the surface at the end, you can leave it as it is. Whereas if you're doing layering technique, that's not the case. You have to use glycerin to fully cure it. Otherwise, you get a micro layer of composite at the end that's uncured and will stain over time. Okay, so this is just the case that walks into your practice every day. It's not a super pretty case, but it's what we see when we in our everyday practice. You'll see that there's composite buttons on the lateral as well as, I don't know if you can see that very clearly, but on the lateral as well as the central. Composite buttons are very important to help us select the correct shade. You apply a little dot without any etchant or bond and you fully cure it prior to any dehydration of the tooth, meaning that's before your rubber dam or anything goes on, we select a shade. Okay, in this case, I don't want to remove any more tooth structure. I just want to smooth off any sharp edges. We etch and we bond. I used a different type of injection molding technique here. And we final polish, and that's the end result. So you will see that this material actually matches pretty well in a case where it's actually difficult to select a shade because there are a multitude of shades in this clinical case. The next technique I will speak to you guys about is layering technique. And it's almost like, how many ways can you slice a cake? So many ways. But this is one of the techniques that you can use to do layering technique. And it's, for example, a kid comes into the office and they've fractured the front tooth. You take the fractured segment, you rebond it, you take an impression with your putty, all done chairside, and then you use that to rebuild up the tooth after your etching and bonding. You want to do a translucent layer. Thereafter, you create your mamelons, and you can do a bit of white staining, even your blue staining to give a bit of incisal translucency, and then you go over with your final shade. This was an interesting case. This patient actually has an anterior open bite, which is why I did what I did here. But again, you can see the composite buttons. Very difficult to take a shade here or match a shade because of what's happening to the tooth. And so you must actually use healthy teeth that are nearby the teeth that you are restoring and not what I've done here. So we root treated the lateral. And then this is actually Speedent's temp material. I told her, I'm not sure if it's gonna last because we don't really have much tooth structure, but we'll try. And it lasted her until the next visit. So I was pretty pleased with that. The etch, and this is the K-bond here. We build the palatal shell and interproximal walls. We do our anatomy, and that's the end result. This case is also almost 7 months old. So, I mean, that's a damn good result for me, that where we have such minimal tooth structure. Also, if you look at the central and the canine, the only reason we can see slight discrepancy is because the teeth in these pictures were directly post-op and they're a bit dehydrated. Okay, so this is my last slide. This is the patient that I'm doing a full rehab on, and we needed to translate to the lab what I wanted in the final outcome. We also placed her in, we were placing her in PMMAs, but we needed something to create a temp for now. And with regards to the shade, I wanted to, showing your technician is the best way. So we scanned this. This entire temp is actually Speedent S-Flow injectable. This patient is also a heavy smoker and a heavy coffee drinker. It didn't stain over 2 weeks, which is how long I had her in it. It didn't chip, which I was very impressed with as well. So, I mean, she asked me why can't she have that as, I said, no. Okay, so I just want to say thank you so much for your attention. I love this quote because curiosity really does push us out of our comfort zone and helps us elevate our dentistry, which is really ethically what we should be doing.